Assalamu alaikum. Good morning. Dr. Abdul Razak will give you an insight of stricture urethra. So thank you very much for your coming. Okay, start.
Assalamu alaikum. Today's presentation will be the first presentation of a series of lectures related to stricture urethra and which we will have in this hall for the coming weeks. We'll start the introduction of this topic today, and the objectives of today's discussion will be the introduction, the basic anatomy of the urethra, epidemiology and evaluation of the urethral stricture. Before we enter for the full discussion of the topic, we would like to start a few questions. What is a stricture urethra?
So who will tell us about the stricture urethra? What is stricture urethra?
So, stricture urethra is a scar in the subepithelial connective tissue of the corpus spongiosum, which will ultimately obstruct the lumen of the urethra. So, since the anterior urethra is this corpus spongiosum is only found in the anterior urethra, so the term stricture urethra is referred to only for the anterior urethra. Whereas the same kind of a narrowing, if it is present in the posterior urethra, then it is termed as a posterior urethral stenosis.
You answered two questions.
It is the entire definition of the urethral.
Okay. Very good definition.
And what about the female stricture urethra? How we define them? Anyone? That's for the male urethra, okay?
कि अगर posterior में narrowing हो जाए तो that is called stenosis. ठीक है? क्यों? अभी ने बताया क्यों क्यों आप पीछे वाला कोई बता दें. ठीक है. Corpus spongiosum is not present around the membranous in the prostatic urethra. Okay. और एक और लिगामेंट जो है वो अटैच होता है यूरेथ्रा से, वो बहुत ही इंपॉर्टेंट है. वो कौन सा लिगामेंट है? मेम्ब्रेनस और प्रोस्टेटिक यूरेथ्रा से होता है. कुछ पता है किसी को? प्यूबिस और प्रोस्टेट के दरमियान होता है प्यूबोप्रोस्टेटिक लिगामेंट. ठीक है, तो चले आगे पढ़ते हैं.
How we define the female urethral stricture? That's the third question. Then we will go forward into the lecture. Yes. Anyone voluntarily, how we define female urethral stricture? Do we call it stricture, stenosis, or just narrowing? So when it comes to the female, there is no agreed universal definition. Female stricture, it can be defined, most of the authors define it fixed anatomical narrowing. They don't say stricture, they don't say stenosis. And that caused reduced urethral caliber. This reduced caliber is variously defined as between less than 10 FR to less than 20 FR, with majority of the series defining it less than 14 FR as diagnostic for female urethral narrowing, compared to the normal urethral caliber, which is 18 to 30 FR.
क्या डेफिनेशन हो गई कोई एक मुझे बता दें. तो जब तक हम मानेंगे ना तो अंदर से हमारी डेफिनेशन नहीं होगी और हम खुद रहेंगे और हम खुद ही रहेंगे. ठीक क्या हो जाएगा इन सारी का यूज कर सकते हैं पर लेस देन 10 पार्ट थोड़ी के पार्ट टेक्नोलॉजी ऑफ के बारे में. तो इसका क्या मतलब हुआ कि इसी cannot pass the 14 FR directly captured through the then it is that
स्ट्रिक्चर यूरेथ्रा. ठीक है, बताओ.
Female stricture is defined as the fixed anatomical narrowing which causes the urethral lumen to reduced in caliber. So we are when we are unable to pass 14 FR Nelton in the female urethra, then we termed it as stricture urethra in females.
आज जो है ना फ्रीडम ऑफ स्पीच है, जो भी बोल सकता है, हर कोई बोल सकता है. ठीक है, तो और गलत बोलें सही बोलें जरूर. ठीक है.
As we start, then the basic anatomy of the urethra. We have the male urethra and the female urethra. In male urethra, we define into two segments, anterior urethra and posterior urethra. On anterior, then it starts from the meatus, fossa navicularis, penile urethra, and then bulbar urethra. From the posterior urethra, there are two divisions. That's the membranous urethra and the prostatic urethra. But when it comes to prostatic urethra, we start from the bladder. It is 3 centimeter in length. It has the widest part near the anterior surface than posterior surface of prostate. On posterior wall, there is median longitudinal bridge, urethral crest on both sides, of which there is shallow depression called prostatic sinus. At the middle part of crest, there is elevation, verumentanum, which marks the position of external urethral sphincter. The membranous part is the least dilatable part. It is 1 to 2 centimeter in length, surrounded by fibers of external urethral sphincter. And here, the urethra perforates the perineal membrane, after which became bulbar urethra, about 1 inch below and behind the pubic symphysis. The penile urethra is the longest part of the anterior urethra, and it passes through the pulp and the corpus spongiosum. And it has a narrow with uniform diameter of 6 mm in body of penis, but it dilated in pulp to form intrapulbar fossa, and in glans it forms navicularis fossa. So this is the pictorial presentation of what we have just read as paragraphs. Pointed out. नहीं है ना? So from here, our anterior urethra starts, which has been divided again into the bulbar urethra and the penile urethra. Okay.
So this is a penile urethra. Okay. This is a penile urethra, and this is U-shaped bulbar urethra, then membranous, and then prostatic. Okay. So I think that penile urethra is about 10 centimeter, 10 to 12 centimeter, and bulbar urethra is also 8 to 10 centimeter. So majority of the urethra comprises of the penile and the bulbar urethra. 2 centimeter for membranous and 2 to 3 centimeter for prostatic. Okay.
So we have sphincters of urethra, internal and external. Internal urethral sphincter made up of smooth muscle fibers, involuntary in nature, supplied by sympathetic nerve T11L2, controls the neck of bladder and prostatic urethra above the opening of ejaculatory duct. External urethral sphincter is made up of striated muscles. It is voluntary in nature, supplied by perineal branch of pudendal nerve, controls the membranous urethra, and responsible for voluntary holding of urine. So this is the blood supply. The blood supply of the urethra starts from the internal pudendal artery. It divides into bulbourethral artery and the dorsal artery. The dorsal artery goes to the dorsal part of the penis and supplies the urethra. And then the bulbourethral artery has a small branch. These are the bulbous branches, and these are the anterior branches. These are the branches to the corpus spongiosum. Over here, you have the cavernous artery, which is very important. These cavernous artery gives small branches, and they will have a communication with the bulbourethral artery.
What is the importance of the double supply of the urethra in terms of the EPA urethroplasty? तो क्या होती है, क्या इसमें क्या फायदा होता है डबल? तो अगर हम ये वाली यूजुअली जो है वो EPA यूरेथ्रोप्लास्टी में आप ये काट देते हैं, ठीक है? You have to cut the bulbourethral artery. तो अगर हम एक ही सप्लाई होती तो फिर क्या होता है कि सारा आगे का यूरेथ्रा जो है वो स्टीनोज हो जाता. तो अब क्या है कि 2 सप्लाई हैं, तो रेट्रोग्रेडली फिर जो है उसको सप्लाई होती है. तो इस वजह से जो है हमारा 2 सप्लाई इज वेरी इंपॉर्टेंट. ओके, सो इफ वी कट दिस आर्टरी, usually we cut this artery in EPA. So the blood supply will goes into the glands and then comes here through this artery. Okay. समझ में आया? रोमान बता दीजिए दोबारा.
The penile urethra is supplied by 2 arteries. If you cut one, the other will continuously supply the
Which artery will cut in the APA?
Pulbourethral.
Which artery will supply after APA to the anterior urethra? Dorsal. Okay. ठीक है. Thank you.
So we will move to the epidemiology. Stricture urethra in male is quite common at the age of 45. Anterior urethra is the most frequently affected, in particularly the bulbar urethra because of the injuries, straddle injuries. In females, the incidence increase of 64 years old, and true stricture occurs in only 0.058 to 5% of women with refractory LUTS. In children, most strictures are traumatic, iatrogenic causes, or external trauma. Pathophysiology is the spongy erectile tissue of the corpus spongiosum underlies.
Causes of urethra.
Traumatic,
क्या होता है?
traumatic,
और number two,
infective cause है,
और क्या हो सकते हैं?
iatrogenic, flowing infection,
और क्या हो सकते हैं? Idiopathic. यानी कोई भी कॉज नहीं मिलता, अगर आपको जो है कोई भी कॉज नहीं मिल रहा तो
Pathophysiology is spongy erectile tissue of the corpus spongiosum underlies the urethral epithelium, and the scarring process extends through the tissue of the corpus spongiosum in some cases and into the adjacent tissues. Contraction of this scar reduces the urethral lumen. If you see here, we have a picture, the anatomy of the anterior urethral stricture in most cases underlying this. So if you see you have a mucosal fold, and B, you have an iris construction, and there is a full thickness involvement with minimal fibrosis in the spongy tissue. And on this one, you have a full thickness spongiofibrosis. Here we have an inflammation at the same time, and here we have with the full thick with the complex stricture complicated with the fistula. This one.
What is straddle? Straddle injury क्या होती है? कोई भी बता. Easy.
It's most common injury in child when they fall on a gutter hole. In young adults, gutter hole directly traumatizing the perineum.
What does it mean, straddle? What
एक मिनट.
You fall on some object by your thigh apart. So there's a direct injury toward into your urethra. Anterior urethra. Anterior urethra.
Urethra.
Bulbar.
If any person fall at the ground and the perineum hits at the ground and the bulbar urethra is crushes between the ground surface and the pubic bone, then this will cause a straddle injury and it will. आप पीछे चले जाएं तो इसमें जो है बहुत ज्यादा फाइब्रोसिस होती है, तो this type of injury is this. इसमें this ये इतनी फाइब्रोसिस होती है, ठीक है. तो फॉर स्ट्रेडल इंजरी वी शुड डू द ईपीए यूरेथ्रोप्लास्टी.
Now we'll move to the etiology. Any process that injures the urethral epithelium or the underlying corpus spongiosum results in a scar and can cause urethral stricture. And these are the proposed causes of urethral stricture. Up to 80% cases are iatrogenic. There is infectious causes, idiopathic, inflammatory, and trauma. A recent meta-analysis of etiology found that most common causes are idiopathic and iatrogenic, followed by post-traumatic and inflammation. Iatrogenic mainly due to diagnostic or therapeutic endoscopic instrumentation, such as TURBT, TURP, instrumental cystoscopy in inexperienced hands, passage of two large-size endoscopies, indwelling catheter for prolonged period, post-prostatectomy, post-amputation of penis. The mechanism is a poor technique of instruments and catheter, large size of instruments, lifting of a mucosal flap, and this is most common at the penile junction. Ischemia of the urethra due to relative compression of the spongy tissue for extended period might be the cause. The incidence of stricture following TURP of the prostate is around 3 to 4% and almost always occurs within the mid-bulbar urethra. Urethral catheterization, when the balloon of the Foley catheter is blown up in the bulbar urethra, or less commonly when it is not sufficiently deflated and is pulled out traumatically. Idiopathic bulbar stricture is most commonly present in developed society and certainly the most common in young men, typically found at the junction of the proximal and mid bulb, usually short and tight. Patients will often present in their late teens to early adulthood, no specific cause. Speculated that it might represent a problem with the blood flow into the rapidly enlarging penis and urethra during puberty in susceptible patients. Sexually transmitted infections cause urethritis and in particularly gonorrhea is one of the most common causes, and it was previously a major cause of urethral stricture in a well-resourced countries, accounting for 40% of all cases. Gonorrhea, most common cause, but now incidence is decreasing because of early management. The sites are bulb, but up to 80% penis scrotal junction, distal part of penile urethra, multiple strictures, and mostly never seen in posterior urethra. Appears within 1 year post-infection, but symptoms might not appear till 10 to 15 years. Other infections are non-specific urethritis, TB urethritis, periurethral abscess. Congenital non-inflammatory short length stricture are not associated with injury in infants, are termed as congenital. Most common sites are EUM and penis scrotal junction. One of the most common causes is also trauma, and the urethra can be damaged by the passage of stone or foreign body. External trauma such as straddle injury, which we have discussed earlier, and the pelvic girdle. So these are the traumatic causes. Accidental trauma. The male urethra can be injured by both penetrating and non-penetrating mechanisms. Penetrating injuries are relatively rare. Penetrating object can be either knife, bullet, or other objects following an explosion, and the non-penetrating trauma such as the plant trauma occur in the crush injury of the bulbar urethra and the destruction injury of the pulbo-membranous urethra. Crash injury or fall astride injury. Perineum is compressed at high velocity against the rigid object, will result in the bulbar urethra being compressed and crushed against the inferior pubic arch of the pelvis. The urethra is usually intact, but urinary extravasation may occur. Urinary retention is almost inevitable, and dense full thickness stricture and obliteration of the urethra is likely to occur. There is BUFD pelvic fracture urethral injuries, mainly secondary to plant trauma. 10% of the pelvic fractures, injuries to the bladder and urethra, pulbo-membranous urethra involved mainly. Destruction injuries unique to membranous urethra. A fall from a great height or compression under heavy object will also have potential to rupture the pelvis and injure the urethra. In most cases, the membranous urethra and prostatic urethra are stretched and potentially separated from the bulbar urethra as the prostate and external sphincter move with the fractured segment away from the more fixed bulbar urethra. Injuries can be incomplete or complete and can be complicated by significant hematoma and subsequent fibrosis around the destruction site. So other causes could be prolonged labor. This puts pressure on fetal head, can put pressure on the urethra, leading to necrosis, then healing, and then stricture, and the urethral growth affects the.
So who will tell about the pelvic fracture urethral injury mechanism? कौन बताएगा?
As a result of a fall from a great height or compression, this will lead to the rupture of the pelvis and the inside the urethra.
Prostatic and membranous urethra are not with the pelvic fracture.
Because they are more susceptible.
They are
They are fixed and they are more,
So they are attached to the pelvic bone.
Yes.
With which
they can be
people prostate.
prostate.
Complications can be outflow obstruction, gradual dilatation of proximal urethra, compensated bladder hypertrophy with diverticulae, then hydronephrosis and hydroureter, stages of urinary infection, prostatitis, cystitis, pyelonephritis, and the stone in bladder, infection of stagnant urine proximal to stricture, abscess, rupture, and ureterocutaneous fistula. And the last part of the lecture is how we evaluate after the introduction and etiology and epidemiology. Before embarking on a treatment, depth, density, length, and location is very necessary to be determined to plan accordingly, which needs certain investigations. We'll take history, then an examination, baseline labs, sonographic evaluation, radiographic technique evaluation, endoscopic, and UFM. There will be no signs generally. It might be palpable in long-standing cases, might be tender mass in case of abscess. UC in long-standing cases, urethroperitoneous fistula. EUM, external urethral meatus, might be closed with area of thickening. The symptoms will be gradual decrease in stream, sudden retention, urinary retention, or lower urinary tract symptoms such as frequency, urgency, nocturia. Usually the patients are young. The other investigations are the RFTs, the urine culture, serology, to rule out the perineal infections, and ultrasound KUV. Radiographic evaluation will be the retrograde cystourethrogram, antegrade cystourethrogram, FSPC in situ, and determine the extent and location of stricture, which is important to decide before intervening the stricture urethra. Retrograde urethrophy demonstrates the total length of a urethral stricture, which cannot be negotiated by cystoscopy. It also demonstrates the anatomy of the urethra distal to a stricture, which might not be accessible by avoiding cystourethrogram. The technique is we take a plain film obtained first before injecting to in the contrast. The patient is usually positioned slightly obliquely to allow evaluation of the full length of urethra. The penis is placed on a slight tension. Small catheter may be inserted into the fossa navicularis with the balloon inflated to 2 cc with sterile water. Contrast then is introduced via catheter-tipped syringe. Alternatively, a penile clamp may be used to occlude the urethra around the catheter. So this is the retrograde urethrogram. Can anyone, the audience, describe us and the picture we have on screen?
Sorry. This is the image of retrograde urethrogram, cystourethrogram, showing
Which one?
on the oblique view.
Which one is retrograde? This one or this one? कौन सी retrograde है कौन सी?
Sorry, the A is retrograde.
A is retrograde.
It's a filling phase that is suggested by the narrowing, sort of narrowing, missing contrast in the membranous as and dilated anterior part of the urethra.
You have to see the bladder neck. The bladder neck is closed and
Yeah.
there is a dilating in the meatus, then at meatus, then this is the retrograde film. Okay. And if there is a dilatation of the bladder neck and bladder neck is open and then you can see the nice posterior urethra, then this is a antegrade film. Okay. So आगे बढ़ो.
On the A image is showing there is a anterior urethra is well opacified with the contrast. There is no such narrowing in the penile and bulbar urethra, and the contrast is easily passing in the membranous and prostatic urethra. No any filling defect or narrowing is noted, and the bladder is well opacified, distended with the contrast. And on the right side, in the image B, it is an oblique view of the antegrade cystourethrogram, showing in a voiding phase, showing well distended bladder, open bladder neck, and well opacified prostatic urethra.
Wall कैसी है?
Smooth wall,
Diverticulum है?
no diverticulum, no filling defect,
And is there any PUR?
no VURA. and the bladder neck is well opened, and the contrast is easily passing without any filling defect or narrowing in the prostatic and membranous urethra. Our bulbar and penile urethra all are well opacified, no any filling defect, no narrowing, no any diverticulum or
एक कोई और बता दीजिए।
So this is also show the cystourethrogram in which there is, this is entry grade urethrogram.
इंडिकेटेड है यहाँ पे कुछ हल्का फुल्का नजर आ रहा है और वहाँ पे सैडल नेक कैसी नजर आ रही है आपको सैडल नेक भी हो गया इंटीग्रेट और प्लेटेंट बंद हो और कंट्रास्ट यहाँ पे जो जा रहा हो यहाँ से कंट्रास्ट जा रहा हो एलेटिन वो जो है
Yes.
रेट्रोग्रेड चलो ब्लैडर नेक फुल ब्लैडर ये सब हमें तो मिली थी वो इसमें क्या बताया था आपने कहा था स्ट्रक्चर
Sir, bulbomembranous junction.
डिसऑर्डर अगर होगा
ओपन ब्लैडर अभी हम आएंगे
एंटीग्रेड में
नहीं एंटीग्रेड में ओपन होगा रेट्रोग्रेड में तो जाएगी नहीं ये प्यूरिटी में यूजुअली होता है आगे चलें
This is the how the X-ray will look like on gonococcal infections and
Panurethritis.
panurethritis. Yes. So we can also use ultrasound. It has a sensitivity and specificity of around 98 to 96%. And evaluation without exposing the gonads to ionizing. The exact length and depth of stricture can be determined on ultrasound, and the severity of stricture segment as well as the anatomy of the periurethral scar. We can also use cystoscopy with little discomfort under LA or GA.
Cystogram should be done in only anterior urethra. Posterior, we can't see the posterior urethra in sonography. Okay.
We can also do cystourethropy with little discomfort and under GA as well as we can evaluate the nature of the urethral mucosa. Pediatric cystoscopy is valuable in evaluation of urethral proximal to narrowing segments. Cystoscopy from above can also be used to get an idea about the bladder neck and the verumentum. UFM is one of the other instruments we can use for the evaluation of the stricture urethra. Can anyone? This will be our last two slides. This is the different patterns we always see when we perform UFM. Can anyone tell us?
UFM on x-axis the time and on y-axis flow rate, and normal curve is dome shaped or parabolic curve and bell shaped curve.
So we have the plateau or bell shape with normal, and then we have staccato interrupted and the plateau and the tower patterns.
Stataco might be in overactive bladder,
Yes.
and interrupted is suggested that constant obstruction, and
So these all are telling us the abnormal flow of the urine, and they always help us to find out the voiding dysfunction. A tower curve may be seen in patients with overactive bladder, a plateau curve with the bladder obstruction, a plateau or staccato in patients with dysfunctional voiding, and interrupted curve in patients with underactive bladder. Thank you, everyone.
Thank you very much. Thank you.